Welcome everyone to today's webinar, Speeding Sepsis Response, University of Utah Health Reduced Cost and Length of Stay for Septic Patients by 10%, sponsored by Spoke. I am Emily Rapley with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll leave time at the end of the hour for a question and answer session. You can submit questions throughout the webinar by typing them into your controls panel in a space labeled Enter a Question for Staff and clicking Send. We look forward to hearing your questions. Additionally, in about a week following the webinar, we will send a copy of the presentation to the email you used to register. We are pleased to welcome Dr. Horton from University of Utah Health and Dr. Mellon from Spoke. I'm pleased to turn the floor over to Dr. Mellon to kick off today's webinar.
Thank you, and I want to thank Becker's for co-hosting this webinar with us. I'm Andrew Mellon. I'm Chief Medical Officer here at Spoke, and it's my pleasure to introduce the primary speaker in this presentation, Dr. Devin Horton. Dr. Horton is a hospitalist with a quality improvement and research interest in detection and treatment of sepsis and in the prediction of clinical decompensation of patients on medical floors. Dr. Horton also serves as an assistant professor in medicine and the director of sepsis in Modified Early Warning System project at the University of Utah. Dr. Horton?
Good morning, everyone. Thank you so much. Thank you, Beckers. Thank you, Spoke, for having me today. As Andrew said, I am at the University of Utah, and I'm located in Salt Lake City, Utah. So we are an institution with 4 hospitals and 10 community clinics. We have a couple thousand physicians, or 1,400 physicians, and about 5,000 employees with several hundred specialties. One of the largest academic medical centers in the Intermountain West. We do use Epic as our main EHR, and not to pat ourselves on the back, but one of the things that we are recognized for is quality and quality improvement and value. We've been in the top 10 of quality for about a decade, and I think last year or the year before we were number 1 along the ranks of Mayo, as well as a couple of years ago we were number 1 as well. We do use Spoke as our main communication platform, sending several 100,000 messages every single month, and we have been able to integrate that into our EHR, which has helped us in several projects, including this one. So to the subject that we will speak of today, and that is sepsis. And if you're on the line or you've logged in to listen to this, it's because you probably know that this is a big deal in institutions, and you may have some interest in working on it or have already been working on it. And it is a top stake issue for just about every hospital, because as Dr. Liu at Kaiser has written about in JAMA and other platforms, in about 1 out of every 2 to 3 patients that die in the hospital have complications or have mortality that's associated with or because of sepsis. It is a large mortality burden to the nation every year. It has been noted as the single most expensive cause of hospitalization, and probably the single top cause of mortality. And as sepsis gets into its later stages of septic shock, by the new definition, it reaches mortality rates of 40 to 50%. So it is a big deal for most institutions. As I go through this presentation and I talk about sepsis and how we approached its clinical conundrum and its operational conundrum, I will do so in the framework of the Plan, Do, Study, Act, which is a lean principle, a quality improvement principle, that it's not as rigorous as randomized controlled trials, but it's something that's done operationally that has rapid ability to find problems in a project, that has multiple human and operational and systems factors, and able to find the problems, study them, and continue in these what's called PDSA cycles. So as part of Plan, as part of P and Plan, under that are both the motivation of motivation of how to find a problem in your institution, how we found our problem, defining the problem, getting baseline data for the problem that that you think you have, and then building a team around that, getting the buy-in and the stakeholders of key players in the institution to then be able to go into the next phase of do. So the motivation behind our project was, my motivation came from, as a second year attendee, and I was fresh out of residency, I was actually on what's called the Internal Medicine Consult Service. And so on that service, rather than my hospitalist role, I answer internal medicine questions for other services like ortho or neurosurgery or what have you. And what I was seeing is I would be consulted for example, fever. And I would go see the patients and I would get into their chart. And sure enough, they did have a fever, but they'd also had vital signs that were significantly abnormal, and they'd had those for several days. And as I went through the notes, you could see our EHR imports those vital signs into the notes every single day. And so you would see those vital signs for 3 or 4 days that had been abnormal, yet when you get to that assessment and plan section of the note, you would see that there was no discussion of those vital signs. And so at some point, the data that was in the computer was not getting to the providers that knew either what to do with it, or the providers weren't seeing it and making correct medical decisions. And so I thought to myself at that point, could there be a way of making these vital signs that are already being imported into the note, and that looks scary to me as an internist, be sent to a person, to a provider that knows what to do with them, and can ensure that the patient is safe and not slipping through the cracks. And through that, I realized that there are residents and providers that couldn't actually define what they were seeing. So despite the fact that patient had elevated white count and a fever and tachycardia and maybe some end organ dysfunction, they couldn't actually put the pieces together to say that was sepsis. So what they would, and when we do some chart reviews, we would see that they would kind of address the fever and the elevated creatinine and the altered mental status all together, are all separate problems, but couldn't kind of put the pieces together. So we understood that there was a recognition problem. Right around that time, I went to the ACP meeting in Orlando, and I saw Dr. Phil Dellinger speak. He's one of the authors of the Surviving Sepsis Guidelines. And in one of his opening statements, he said that this is the #1 cause of mortality in hospitals. And that statement was simple and yet was striking to me. I hadn't realized that as I was going through as a resident. And I realized that no one had told me that ever, and that I didn't think at that time that we really had a campaign in process, or a process in place at our institution to address that. And as I went back to the institution and started looking into it and asking quality people to look into it, we did realize that there was, in fact, no real process in place. And then, of course, we were anecdotally, as I was going through my day-to-day service, I was anecdotally seeing that there was delay in recognition and delay in treatment of these patients. So the next thing that we did was define the problem for us. So what was happening at our institution, how it affected our mortality, understanding what the gold standard treatment was. And I didn't know at that time what the gold standard treatment was, and a lot of providers did not. We wanted to see how good we were at meeting that gold standard treatment, and then understanding if our nurses and residents, our frontline providers, could recognize patients that had this pathology. What we found after our quality experts were able to pull the data, including one of our analysts, John Arago, found that 42% of all of our mortality was associated with sepsis, and that again, that was pretty consistent with what Vincent Liu and other experts have been finding, that 1 out of every 2 or 1 out of every 3 deaths in the hospital has sepsis associated with it. That most of our sepsis were admitted through the ER, and 15% about what happened on the floor, or was new sepsis in the hospital. And that we at the University of Utah accept quite a few transfers, and that those transfers, when they have the diagnosis of sepsis, they have quite a high mortality rate. And of course, that it affects we found that it affects all the patients in our hospital, including medicine patients, but also ortho, ENT, oncology. So it really was a final common pathway for many of our patients, and mortality and morbidity that could happen with our patients. Looking to the literature, we discovered that there were that there was a gold standard and that the surviving sepsis guidelines were out there, and that they stated that after 3 hours, or that within 1 to 3 hours of recognition of severe sepsis or septic shock, that lactate should be obtained, blood culture should be obtained, broad spectrum antibiotics should be given, and that a significant amount of fluid should be given, or appropriate amount of fluid should be given. We then looked at our own institution to see how we were meeting those goals, and the blue line would be 3 hours. We found that through chart review of several hundred charts that we weren't meeting the goal that is considered the gold standard. So we had defined the problem. We had looked at our own institution to understand the problem. We had motivation behind the problem. And then we wanted to know, of course, if what I was anecdotally seeing, or what we were anecdotally seeing, was indeed the case, that residents and nurses had a hard time recognizing this. And so we developed a survey or a questionnaire, 21 questions, I think 3 or 4 pages, some of which were open-ended questions, including giving a clinical scenario that had a patient with an opacity on a chest x-ray, a fever, a white count, and a lactate of 3 or 4, and kind of seeing what people thought of, what providers thought of when they saw that scenario. Did they think of sepsis as a condition, or did they see pneumonia as a condition? And we did find kind of more so the latter, that they would kind of see the pneumonia and not necessarily see the end organ dysfunction, or they would not really even see the pneumonia either. In addition, we had some questions that looked at, provided the options of sepsis, severe sepsis, septic shock, and asked them to kind of ask the providers and the nurses to see if they could pick from that spectrum where the patient in the clinical vignette was. And we saw that the residents we were able to get about 56% of the questions right, and the nurses around 20% of the questions right. And so that kind of fed into what we were anecdotally seeing, which is that there was a recognition or an understanding problem as well. And I'd just like to make a caveat right here that during the middle of our initiative, the definitions changed. And so what I'll be referring to for the rest of the talk will be really the SEP 2, or the previous definitions of sepsis, severe sepsis, and septic shock. And we are continuing to use those in our institution. CMS hasn't accepted those, though I do teach these new definitions on the wards as clinical and academic knowledge. So the next thing that we had to do in order to plan our project was to identify key stakeholders and to build our team. And of course, that incorporated physicians, including my partner, Kenzie Graves, who has now moved on to a different position, but who was key in helping this project have its success. And we also needed senior physician support, including our Chief Quality Officer, Bob Pendleton, and Chief Medical Officer, Tom Miller. But we needed nursing support as well. That included nursing leadership, getting their buy-in and having them be stakeholders, and then also having our nursing representation at the table. And this ended up being very important. In fact, we often say this is the secret sauce of our project, was getting the nurses and the HCAs at the table and asking them to really build workflows that worked for them, and actually just having them build it, and then we would come back and see what they built, rather than have us dictate to them what needed to be done. We gave them kind of the knowledge and the goals, and then they would come back to us and say, hey, we think this is what's going to work for our unit for us. So we had those stakeholders and those representatives at the table, nursing education representatives at the table that were ready to go out and basically teach an army of HCAs and residents about decompensating patients, about sepsis. We needed pharmacy representatives there in order to get the appropriate antibiotics on the floor and in the quick pharmacy, or in the quick medical, now I'm blanking on what they call them, but where they keep the quick medications on the floor, so they can treat this as an emergency and get the antibiotics quickly to them, and also getting the appropriate antibiotics. In addition to that, and this also comes back to the physicians, we had key stakeholders from the ICU, key stakeholders from infectious disease, key stakeholders from antibiotic stewardship program, all there to make a group decision on lots of things, so that there wasn't anyone that was feeling alienated, and really making it a group decision. We had key stakeholders and help from our IT, and we were assigned an IT person who was wonderful and able to build software to make the different platforms talk to each other. our rapid response team was important, as I'll get into later on in the presentation, as were our value engineers. Matt Stanford and Colin Seaborn were there, and value engineers at our institution are industrial engineers outside of medicine who can come in and see problems from getting systems and projects done. We had our laboratory and, of course, our quality experts all at the table. Getting these stakeholders and getting this buy-in was probably one of the most difficult and one of the most important things that we did. The next thing was what you call going to the Gemba in kind of the lean or quality improvement world, and that means going to the actual place where things are happening. So when we went to the actual place where things were happening, that's at the bedside of the patients, what we saw was that the nursing assistants or the HCAs, the healthcare assistants at our institution, they would take down vital signs, they'd write them down on a napkin, they'd go see the next patient, they'd take down vital signs, they'd write them down on a napkin, they'd go to the next patient, take down vital signs, write them down on a napkin. So they'd do that, for 4 or 5 or 6 patients. And then they would write down and they'd log all of those vital signs. And you can imagine that first patient's vital signs were now an hour, half hour to an hour old. And so if we consider this an urgent thing or an emergent thing, we've already lost an hour. Once that information was entered into Epic, depending on how good or knowledgeable the HCA nurses were, there was either communication about those vital signs or there was not. And those vital signs just sat in the computer and waited for the nurse to see them when they opened up the chart. They would then page the provider, and the provider might get back to them quickly or they might not. Maybe the provider was in another room, maybe they were pretty busy. Then there was maybe a discussion, and then maybe the providers would go see the patient, or maybe they would not. Maybe they would disregard the nurse, and then maybe they would say, okay, this sounds like infection. Let's order some lactate and fluids and antibiotics. Then there was the pharmacy approval, et cetera, et cetera. So you can see that every step in this is kind of painstakingly long. And we did have one case where blood cultures were called to the intern. The intern didn't really know what antibiotics to order. They chose, it was a E. coli. They chose vancomycin and meropenem. The vancomycin was given was given first and ran over a long period of time, and that wasn't going to treat the E. coli. And that patient went down for a GI procedure, and the meropenem sat around on the floor for 5 hours. The patient came back, finally got their meropenem, and then went into shock a couple hours later because there was just such a delay in treatment, including missing the diagnosis the day before. So the challenges we found in summary were, it's difficult. Sepsis is a difficult thing to identify. It's not like an MI or stroke where the patient looks at you and says, hey, I have chest pain, or there's facial droop or something like that. Like, it's a very subtle and difficult thing to identify. And we did find that in our institution. We also found that there's multiple steps. There was multiple steps in our process to have human error, to have nurses that were nervous to call doctors, to have doctors that were disregarding nurses or didn't want to come see patients. And we didn't really have a force function. We didn't really have a threshold that said, look, at this point, lots of fevers happen. Okay, we don't necessarily need to see every patient with a fever, but at some point we need to say as an institution, this patient should be seen and should be seen quickly, and we should consider this patient an emergency or an urgent person to see. So then we went into designing the project and getting the education going and implementing the change. It started out on a pad of paper, brainstorming, writing down how we thought things should go from the time of vital sign abnormalities, what processes should happen, who should be contacted. It developed, from a pad of paper to a whiteboard, and eventually made into something what's called a process map. And basically on the y-axis there, you can see the different providers that are involved. And on the x-axis is basically time. So what are the different people doing at different time periods as this patient is becoming sicker and sicker? And in designing the system, we kept in mind one of these principles of quality improvement. And this basically is a spectrum of helpful things to not very helpful things to change the system. Kind of the least helpful thing is just to tell everyone to be more careful. Then maybe you put some education out there and tell them, this is what sepsis is, and then kind of, the bad of that would be to stop there and then kind of run for the hills and not do anything, just leave the education. The next thing would be to put a policy in place about doing the education. And then you start getting into things that have a little bit more meat on them, developing checklists so that when X or Y happens, or when you see X and Y, you do A, B, and C, standardizing that. When you put in a Foley, you always do it the same way. When you see sepsis, you always treat it the same way. If you can enter in automation or computerization, that was one of our goals as well, so that the computer can detect some things for you, and then forcing some functions. And that ultimately, that was what we wanted to get to, was where there was a set of vital signs or a sick patient that was identified in some manner that would then force a function. It would take out, the shy nurse, or take out the mean doctor, or whatever, and just automatically send the page. And basically we called it like a medical decision timeout, that everyone would have to take a breath and go and see the patient, or take the patient seriously. And this is an algorithm or a picture that came out after we had started, but basically kept this same principle in mind, or emphasized this principle. You can see that the x-axis on the bottom is time, and on the top, on the x-axis, is as the patient goes from being sick to severely sick to critically sick. And you can see in the middle there, the dotted line is the risk of mortality over time as you continue to wait before doing anything. And the black line is the ability to prevent deterioration with just limited things, limited therapies that you can do on the floor. And the authors of this paper felt that ordinary clinical judgment was right before that cliff where the two lines crossed and mortality really went up, and there was kind of not a lot more you can do with limited interventions, and basically the patient would need to go to the ICU. The idea is that if you have an EMR-based algorithm, that patients can be detected earlier on and feasibly can be resuscitated earlier as well with limited interventions. We also needed to pick that trigger. So I keep alluding to, when you send alert and how you, and that was kind of what we wanted to do, but we didn't have an idea of at what point do we send the alert. And this was an area that was actually pretty difficult for us. We really wanted to err on the side of not causing alert fatigue for our providers. We had talked to other institutions where their alert had been too sensitive, and that providers were getting frustrated, and they had kind of lost the battle before they had even begun to really make progress. And so if anything, when we started out, we wanted to err on the side of really getting our providers alerts only when the patient was pretty sick, and when the provider got to the bedside, they were grateful to be there rather than to be frustrated to be there. And so SIRS just wasn't going to work for us. SIRS, there was a paper that was produced a couple, right around the time that we were starting this, that showed that 50% of all inpatients have SIRS some time during their hospitalization, and alerting providers to 50% of patients just wasn't something that we could do. So MEWS, or an early warning system, or a modified early warning system, gave us something that we could find patients that were a little bit sicker. And this is an article from Resuscitation that they called their early warning system VIEWS, but you can see as they're on the x-axis, as their early warning system or VIEWS score got higher and higher, the thin line that goes, that's the mortality in 24 hours. So you can see that as you go from 8 and 9 to 10 to 11, your mortality really goes up. But the black bars were frequency of alerts. So you can see that as you go up further, the frequency of alerts actually is not very high. And all this system really is assigning a single digit point, or a single digit number, 0, 1, 2, or 3, to a spectrum of vital signs, to a range of vital signs. So if you have a normal pulse, you're 0, and if you have a very abnormal pulse, you're 3. And if you have 2 set of vital signs that are very abnormal, you have 6 points. And this is the early warning system that we came up with. And we took basically this one that had been published already. We showed it to our providers and our experts, quote unquote, and asked them for feedback and if they thought it was reasonable. And some things were tinkered with. We changed the heart rate on some and the respiratory rate on others. Said we'd give more points for this and less points for that, and that was based on our institutional feedback, because we wanted our institution to be happy with this. Once we had our vital signs mostly sorted out, then we looked at our institutional internal data. And so we wanted to know what the mortality was for these different MEWS scores, so that we could, again, pick our threshold for sending out that alert. Well, we looked at mortality, and we also looked at alerts per week per floor. So one of the things we found, for example, that as you go from a 4 to a 5, your mortality goes from a 4% to 11%, so about a doubling. but our alerts were actually half for 5 as they were for 4. And so we wanted to hedge on the side of, again, not sending quite as many alerts out in the beginning and really finding those high mortality patients so that our providers are glad that they're there and they're getting half as many alerts per week. So we went into this with basically a multifaceted approach. We were going to educate our nursing staff and our providers. We were going to build something into IT with a force function that we had already decided upon, based on our mortality and our alerts per week, which scores we were going to make our force functioning, where there's an automatic page to the providers, and then ensuring that those providers are getting the pages into their devices. Part of our education, and again, education alone, we didn't think was a great thing, as we remember from that scale of quality improvement, but education was important still. And we really wanted to focus a lot of our education on the HCAs and the nurses and tell our HCAs that their job is really important, that we can have the best hospital in the world, but if you don't know what vital signs are, and if the vital signs aren't entered in the computer in real time, then that patient is losing and the institution is losing. So we tried to empower them and really told them that their job was really important, to get vital signs accurately, to get them in the computer quickly, and to change the napkin dropping and the napkin collecting. And that was a big cultural shift, and that's something that they took pride in. We also educated the residents, and we did do some post-education surveys, and it told us what we thought, that education was okay and it was good, but that it does have a ceiling effect. You can see that our residents didn't change that much, despite literally us going to every single resident and giving a PowerPoint presentation. However, our nurses did jump quite a bit, so they nearly doubled their knowledge base, and so we'll take the win for that, and also understand that it has a ceiling effect. We also provided resources for the nurses. Again, our HCAs and our nurses, they are the ones that we wanted to support. So me and my partner, Kenzie, were basically on call 24 hours a day, 365 days a year for anything that went wrong in the pathway or in the system. Now, honestly, we were probably only called a couple times, but just them knowing that we were there supporting them. If a resident was going to give them pushback, that we were there to have their back and to support them, that was important to them, including giving them, scripted things to read to their docs. Basically, you can see kind of almost to the bottom there, it says all department leaders have agreed that these patients should be evaluated. So that if there was some resident, in the middle of the night, or a grumpy doctor that said, I'm not going to come see this patient, that they could say, look, your leaders have decided upon this, and kind of give, again, to support the nurses and the HCAs. This is ultimately the pathway that we came up with. So the HCAs, the nursing aides, would take the vital signs and enter them in real time directly into Epic. And when they were outside the normal range that I already showed you, that the modified early warning systems scale or vital sign ranges that we had already decided upon, when they were outside of that range, an alert was triggered as soon as the vital signs were put in, and a page was sent automatically to the charge nurse. And there was 2 levels. So we decided on our thresholds to be 5, and I forgot to mention when we were on the mortality slide, but once you get to about 8, your mortality is about 40%. So we decided that at that level, we actually wanted a rapid response call. We wanted SICU nurses at the bedside. We wanted a little bit more urgency. So at a level 5, there was a page that was automatically sent to the charge nurse, and the charge nurse was then responsible to get the doctor at the bedside and to get to the nurse at the bedside nurse. Once the bedside nurse was there, he or she would, ensure that those vital signs were accurate, and would have an alert that came up on the screen when they opened up the patient's chart that allowed them to go directly into ordering lactate and a couple other things that we'll look at later, to get the assessment of the severity of illness going even before the doctors are there, actually. And then if it is an 8, so if it was a 5, part of the education, we asked our providers to be there within 30 minutes to evaluate the patient. If it was a 5, 6 or 7, and if it was an 8, that the provider be there within 15 minutes. And our rapid response was usually there within 5 or 7 minutes. Fortunately, this slide didn't work out. So what's one of the alerts that would come up to the nurses, and they would say, basically, this is concerning for the safety of your patient. They would click accept. That would send them to this order set. They would order a lactic acid now. They would order a lactic acid, in 4 hours. If that first one were abnormal, they'd get some blood cultures going. The sepsis protocol in progress order would snooze the alert. So that was part of our system as well. If there was a MEWS of 6 and the patient was evaluated, it would be snoozed for 24 hours, so that if that patient was, assessed, resuscitated, or assessed and decided, say, you know what, we've resuscitated appropriately, we're going to just monitor this patient, then they wouldn't be alerted every 5 minutes or every 2 hours. But that if it went into the second level, if it went up to the 8, that the rapid response would still be called. However, once the rapid response is called, the system again be snoozed for another 24 hours from the level of the 8. Again, so we weren't calling responses every 2 hours on these patients. And of course, the frequency of vital signs was increased. Once the providers were at the bedside of the patient, they would open up they would have an alert too, and they would get some educational information that said, hey, these are the definitions of what sepsis is. And these are also some non-infection causes of SIRS or abnormal vital signs, again, to kind of maybe educate them at that point of care about what sepsis is and about what other things that can cause sepsis mimickers. So once we had that, had the process all squared away and had gotten the education and had built the software, we then started our pilot project, and we started on what's called our acute internal medicine A unit. And we developed then a checklist of things that needed to happen before we could roll out to a unit. And we did this every single unit over the course of about a year. And so you can see on the right side, a lot of this was, some of this was buy-in. So talking to our chief value officer, our nursing leadership, our nursing directors, our medical directors, getting buy-in, getting their feedback, tinkering with the system if they needed it. We actually let the leaders select their MEWS score. And that, I think that made it feel like we weren't forcing it upon them. They could kind of look at the data and say, okay, this is the alerts per floor per week. This is the mortality. Where do you want your providers to be called? And that's what that gave them a little bit of ownership, and probably took some of the blame away from us, if things didn't go quite as planned. But they ultimately all ended up coming to the same score on their own. And we would sometimes tell them what other floors were doing, and they would choose that. We would give education presentations to the physicians of that unit or of that department. We would let our education nurses educate the nurses on that unit and the HCAs. Let the nurses and HCAs start the process maps. We would then involve our value engineers to help with the workflow. We'd get IT involved and have our nursing IT talk with our main IT guys to get that perfect, or as perfect as it could be. We would have a testing event to ensure that the pagers were working and that Epic was able to send out the pages to the correct device. We'd have a lab, and then we would go live, and then we kind of cross our fingers, and we would always find problems after go live, and we would sort them out as they came up. And that kind of brings us right into study. So as once we go live, we would see, gosh, what was the effect of that? How did it work out? There's so many things that come up that you just don't plan for in such a complicated system, such as an academic medical center. And so there was always things that we needed to work on, get feedback from the people on the ground, and then we would go in and try to change those things to improve it. One thing that was helpful for us was that we had all of our MEWS or sepsis data stored into one place. So at least at our institution, we have several data sources. We have Epic, we have Lab, billing, et cetera, and that all drops its data into something called the data warehouse. And it's this big, exactly what it sounds like, a big data warehouse. And we didn't want all of that data. We wanted to be able to look at it easier. And so we had one of our data warehouse architects build us something called the MEWS universe, or the sepsis universe. And that was just the data that we were interested in: length of stay, lactic acid, mortality, ICU, et cetera. And so then we were able to look at that data and take that back to our providers and tell them what we were seeing. So for example, we were able to look at the association of lactic acid with our MEWS patients to say, hey, is lactic acid an important thing? Is it helpful? Well, yeah, it looks like, if it's greater than 4+, then that patient actually has quite a bit higher mortality than patients with 0 to 2. And we actually looked at that for every MEWS score. We looked at, the ability for this to predict, our system to predict whether patients were going to the ICU, look at its ability to predict bacteremia, and we were also use that data to look at the ED's ability to obtain what we call perfect care, which basically is just the bundle, getting blood cultures, antibiotics, fluid, pressors if needed. And the two red lines here are actually our first go live with MEWS, and you can see maybe a little bit of an uptrend in perfect care after that. But what we found out, and what I'll talk about a little bit later, is that it actually didn't go that well in the ED, so we had to come up with something else. So because of the data we were collecting, we were able to look at the odds of our septic patients getting antibiotics in the first 24 hours. We saw an increase in that. We didn't see an increase in broad spectrum antibiotics. We did see a length of stay that was decreased by 10%, and because of that, there was a decrease in direct cost that was decreased by 10%. And this is for all sepsis patients. That was done by one of our PhDs, and this data, similar data, was looked at by one of our value engineers for more of an operational standpoint, and they saw the same 10% decrease in cost. And that, again, that didn't include the beds that were being opened up by patients going home earlier and being able to accept new patients, and the institution be able to get revenue from those new patients. So once we were able to find the different problems that were coming up, we acted on those problems, we tried to address them, we made new changes, we redefined the scope if necessary. One of the things that we changed after about 6 months was our threshold score. So I told you that we originally started at 5 and 8 because we saw that mortality at about 5 was about a 10, and this slide is a little bit different data, but the other institutional data that we saw at about an 8 was about 40% mortality. And then about 6 months after, we actually saw that the 8, and so to orient you, the green was a decrease in mortality, yellow was a slight increase, and then red was a big increase in mortality. And so we were a little bit frustrated because we saw that our mortality for our MEWS of 7 was going up, and the original data that we pulled had predicted a rapid response or a score of 8 about once per week per unit. And what we were finding was actually once per month per unit. And so we felt, gosh, maybe we can, again, we'd always aimed at not over alerting our providers. And once we had it rolled out and the providers relaxed a little bit and didn't feel like this was going to ruin their day, then we could kind of tighten down the screws a little bit and adjust it to pick up those a little bit less sick patients. So we actually, we took it to our leadership and we showed them the data. And our PDSA cycles, we had to go back to the ED. As I mentioned, that the MEWS and the technology wasn't working very well there, and so we had to make some adjustments. We modified some triggers, like I just mentioned in this last one. Our PDSA cycles continued. We modified some of our rapid response things that came up, and as we went into the cancer center, we had other things that came up that we needed to modify. Our snoozing capability, we found that we needed to modify. What we found is our nurses were canceling out of order set, and that was canceling the snooze, and so there were just repeat alerts, and so we made that more automatic. This is part of our ED protocol that we went to in kind of what we call MEWS 2.0. As I mentioned, it didn't really work that well in the ED, so what we decided, we were missing some patients that weren't quite sick enough to trigger a MEWS. The MEWS was also picking up patients who had other problems that were not sepsis. And so we made this more of a triage protocol. As I was mentioning, in the ED, the automatic system actually wasn't working. And so we got some feedback from them that for the RNs in the ED, that really they actually like checklists. And so just like for their STEMI and for their brain attack protocol, that they wanted to create a checklist. So we created something for them to screen early in triage, for SIRS, for infection, what we call game changers like altered mental status and low blood pressure. And then at the bottom, you can see, if the lactic acid is greater than 4, blood pressure is still less than 90 to go to the MICU. The lessons that we learned in this 3 or 4 year implementation process were really we needed to understand the state of what sepsis was at our hospital, or that's what you would need to do, understand what recognition's like, what detection's like. Maybe it's great, maybe it's fantastic, maybe you don't have a problem, or maybe you just need to have some nuances here and there. And then tailoring alerts to meet the institutional needs. We had to tailor our alerts in the ED and to the floor, and we actually gave all of our different floors the option to tailor their needs. We learned to leverage the EHR for clinical decision support, and we found that you could do that we could find a threshold that we decided to be a force functioning that would send an alert to the appropriate providers, and that we were able to hardwire that communication to that notification in order to speed up our response. And then, depending on what everyone's resources are, to measuring it the best you can. It's not always perfect. It's not, the measurements aren't going to always make it into the New England Journal, but it might be good enough to help your institution to improve the process, improve the system, and find the successes that work, and then expand them throughout the hospital. And really, that's all I have. I'm going to turn over the time to Dr. Mellon.
Thank you, Dr. Horton. First, a very, very impressive effort on your part and your team's part. I just love how you took a holistic view of this problem, kind of left no stone unturned, got to the bedside, watched how people are actually doing their work, and then hardwired these processes. Also, I think it was great how you took advantage of your existing technologies, especially around communication, where you have the interoperability to pull the data from the EHR. You're able to communicate with the different groups of people, no matter how they choose to communicate. And you're able to do this across the health system to the different groups with a common way of communicating. So again, a very, very impressive project. And I hope for the audience today that they picked up a number of tips and tricks and things that they can bring back to their institution. We have a bunch of questions. I just have a couple I'd like to ask you, Devin, before we turn it back to Beckers for the questions. So the first question I have for you is, how important was it to be able to hardwire the communication processes and eliminate the human factors related to communications that can lead to delays and errors?
Yeah, I mean, I really feel like that is such an important part. As I mentioned, there's just so many human hesitations, and sometimes it's a new nurse or a new HCA that's nervous, or maybe they had a bad experience with a provider earlier, and so there's hesitation to call a rapid response. That's a lot of the data around rapid responses is around people not wanting to call them sometimes, and so this gives you a chance to take it almost out of the hands of the humans. And if you decide before, amongst the leaders, and say, look, once we reach this threshold, this other stuff is going to happen, and then you let the computer system look for those and then call out that response. And if it's a false response, then it's okay, you learn from it. But really setting a threshold, putting a line in the sand, and saying this is going to be our threshold that we have a response.
That's great. And then one last question. As you think about what's next, do you see other areas in the hospital where this approach to improvement could be applied?
I think it's any time that you're nervous that a piece of data is going to be left in the EHR and not be recognized or not be responded to. And that was what's happening with our vital signs. The vital signs were there. Remember, they were there. They were there every day, but they were just sat there and there was no action on them. And so if if it's a troponin greater than whatever you decide it is, 2 or 5 or 10, or if there's a level that makes you nervous and you don't want that to be there, some labs are good at calling out critical values. But for example, we still can't get our pulmonary lab to call out critical lactic acid values. And so maybe, you say, okay, at a 4, we're going to have that just be an automatic response. Or if the EKG says this, it's an automatic response. So I think anytime you need to take, and I don't like to say take it out of the human's hands, but sometimes you need this automatic response when you're scared a piece of data is going to be missed.
Excellent. Well, with that, I'd like to turn it over to the moderators at Becker's to go through some questions.
Thank you, Dr. Mellon and Dr. Horton. That was a fantastic presentation. So we will now begin taking questions from our audience. As a quick reminder to the audience, you can submit any questions you have by typing them into the control panel where it says enter a question for staff and then clicking send. And we will try to get through as many questions as we have time for. So let's go ahead and get started. We already have a lot of great questions. Our first audience question is, what questionnaire was used to check the sepsis knowledge for nurses and residents?
It was a questionnaire that we came up with. And we did work, we tried, throughout this whole thing, we tried to marry quality improvement with academia and do it the best we could. It's a hard marriage because there's very different kind of views on how those things should be done. And I would say that it didn't work all the time. But we did meet with some of our survey developers over in what we call Research Park that have PhDs in how you develop a survey and how you do questionnaires. And so we kind of did the best we can, with the time limits that we had to develop something. And again, we were mindful. We did open-ended questions first, just to see. We didn't want to spoil their open-ended questions by the fact that the survey was even on sepsis. So we went in, and it was all done by person. So we had trained people doing the surveys, including myself and including Kenzie. We'd give them the paper survey. The first page was open-ended just to see what kind of came to their brain first. The second page had the words sepsis and SIRS and shock on it. And then they were asked to kind of see if they could figure out, who's in which state. And then the third page was a page that actually just asked them for the definition to see if people actually knew the definitions or not.
Perfect. Thank you so much for breaking that down. So our next question is, would some identification and detection of a number of pathogens in an hour make differences at early onset recognition of sepsis in terms of RX or other diagnostic testing?
Say it one more time.
Sure thing. Would some identification and detection of a number of pathogens in an hour make differences at early onset recognition of sepsis in terms of RX or other diagnostic testing?
Yeah, of course. So, and I think some of this technology is already out there. I think BioFire here is doing some of that in Utah. If you know that within the first hour that's E. coli, just like on that, I guess on my blood culture example wasn't a good one, but if the ED docs know that it's E. coli within that first hour, then they give that patient, ceftriaxone. Whereas if they know it's MRSA, they give them vancomycin. So from a stewardship standpoint, and again, we were always so mindful about stewardship because we were so scared that we were going to, cause C. diff on everyone or give everyone the diagnosis of sepsis. But if you could do that up front and say, this is what the bug is, and that would narrow their antibiotics very quickly.
Perfect. Thank you. So our next question is about kids. What system do you use for babies and kids?
Good question. So we've worked a little bit with we actually worked a little bit with the NICU, the neonatal ICU, and a little bit with the pediatric ICU, but it's been preliminary conversations, and we haven't directly done any projects with them. They've kind of come over and met with us and learned from some of our mistakes, and I don't actually know their current state.
Okay, perfect. Thank you for clarifying that. So our next question from the audience, have you been able to determine your detection specificity using the MEWS approach you've chosen?
Let's see if I can answer that. I don't think we have gone back to look at that yet. No, we have not gone back to look at that yet, but it's a great thing. It's a great thing to look at. We have been looked at, we've looked at, like I think I showed our rates of bacteremia and when there's a sepsis code, and kind of how the MEWS escalates and what the rate of that is. We do have a surgical fellow that right now is looking at the surgical population, but that is something that that we are interested in, and we're trying to get some funding right now for a statistician that can be dedicated towards this, where we are going to look at how both our MEWS system compares to other early warning systems that are out there. And I'm not married to this early warning system. It can be anything, in my opinion. Whatever is the best thing or the safest thing, and if we find that eCart is another one that's out there, or the different ones are better, then we're happy to go over and to go to that.
Perfect, thank you. And while we're talking about MEWS, could you just repeat for us what the M stands for in MEWS?
It's modified, and again, I didn't come up with this. It's just this is in the literature, and I think modified I think that gives you the caveat of it can be for your institution. So the one we took our modeling from was called VIEWS, and they actually included urine output and altered mental status, and we were working basically with such basics, and I mean our system is so basic. And we wanted things to be so simple so that when we rolled out, it wasn't complicated and stressful for everyone involved and burdensome to the providers. We wanted it simple. And so we even felt like mental status would, while I think it's a very important clinically, putting a mental status in there is not something that's done on routine vital signs. And because of that, and because it wasn't always charted. Mental status isn't charted on our inpatients, on every patient, on every vital sign check. I think should be, but because it wasn't, we went with something that was more simple. And our future plans are to go on and to see if we should start tinkering with that and improving it and including other things.
Perfect, thank you. That's really helpful to understand. So our next question is a little more high level. It's a great question. What, in your opinion, was the biggest hurdle? People, systems, or something else?
People. Yeah, people. There was a lot of suspicion towards what we were doing, and this is where that buy-in and stakeholder thing goes. So there was a lot of one-on-one conversations that had to happen. And I don't blame anyone. I mean, the institutions, institutional medicine in general, hospitals, insurance, I mean, they ask a lot of our docs. And so asking, giving one new idea or one more thing that needs to happen. And we have academic, brilliant doctors, and so they should be skeptical of new stuff. And there was a lot of questions of what's the data on this, and why do you think we should do this? And I don't agree with this. And so a lot of it came down to these one-on-one conversations that we had with people that were worried about doing this. And a lot of times it was like, okay, well, do you think that asking big, high-level questions, like, do you think it's good to find deteriorating patients on the floor? And most people said, yeah, that sounds like a reasonable idea. Okay, do you think that vital signs are a good indicator of deterioration? Oh, yeah, vital signs are a good indication. Okay, so what heart rate, what makes you scared? Is it 110? Is it 130? Is it 160? Is it 210? At some point, everyone starts to say, oh no, that sounds like it's a high heart rate. I would personally want to be notified by that automatically. And so then once you start to get there, and then they can say, okay, I think 160 should be the number. And so you say, okay, let's use 160. And then it kind of became their idea, and they had some skin in the game, and that was kind of how we moved through those hurdles.
That makes a lot of sense. So we have just about 2 minutes left. We have time for one or two more questions. The next question, what were the options for nursing to select on your alert?
Just accept and cancel. And we did get a little bit stuck in, we had to work within the restraints of Epic. And sometimes that was frustrating. And Epic does lots of great things, but it doesn't do other things. And one thing, for example, you can't gray out the cancel button. So that always has to be there. What I would have loved to have done is said, had a button that said, great, thank you for the information, and just have them click that every time. And that's where we kind of got stuck with the snoozes, is because you had to click accept to make it snooze. And a lot of nurses, and I think a lot of us, when we see an alert, we want that alert to go away as fast as we can. And cancel is a great way to get rid of an alert. And so they would cancel out of it because they didn't know what to do, or maybe they hadn't been educated, or maybe they'd forgotten, or maybe they were stressed. And so then the snoozes would go away, and it wouldn't open up the order set. And so that's the answer to that question.
Perfect. Thank you, Dr. Horton. And just one last question from the audience. How has your work impacted SEP1 core measure performance?
It's improved it a lot. I think back when we were mostly in the 24%, I think, before this work started. And we're now, the most recent data, we're pretty consistently in the 60% CMS capture rate. And I think that kind of nationally, 40% is kind of like it's like 40 or 50% is one of the kind of like what the goal should be. And so we're now consistently at the goal, and whereas we used to be consistently below the goal.
Perfect. Thank you so much for clarifying that. And unfortunately, that is all the time we have for today. I would like to thank Dr. Horton and Dr. Mellon for their excellent presentation and Spoke for sponsoring today's webinar. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.